Thank you so much for the opportunity to be here today and to celebrate such an important piece of work that has been done by the team over the last 4 years. I bring greetings from Australia. This is a koala who adopted the research team at the hospital where I worked. He literally took over the tree just outside the research team's office and was given the name Kenny for some reason. Today my talk is really to reflect behind closed doors, a private conversation, if you will, because it is going to be a different conversation. It's going to be a conversation about some of the challenges that I see in palliative care if we're going to achieve integration over the next decade. And to put that in context, I think there is a very narrow window of opportunity. That if we do not get this right in the next few years, funders particularly are going to just leave us at that funding level and walk away. So we have a window of opportunity, but we need to take it. So today is to reflect, to consider, and to think about the future and what we can achieve in that future. I was phoned very shortly after taking a new job. One of those phone calls from someone you've never heard of who said, "We must have coffee." Now, I don't know about you, but my ears prick up then, and I think if I must have coffee, then coffee I will have. And this was a retired senior national bureaucrat. And I arrived at Coffee Dually a couple of weeks later. Don't do a lot of coffee, but this was clearly going to be an important cup of coffee. And his opening words to me were, "You know the problem with palliative care?" I love conversations that start with, "You know the problem with palliative care?" And so I sat down and he said, "The problem with palliative care is you are funded as a social good. You are funded to make the rest of the community feel better, not because you have made the case that you are improving the health of the community." And he gave me the challenge that day of how do we ensure that we have conveyed to the community and therefore to our lawmakers and our funders that we are actually part of the health equation, that an investment in palliative care is genuinely going to improve the health of the community in which we live. We're talking about integration today, and another contrasting conversation was soon after I had started a new job. In fact, it was the first time they had appointed a palliative care physician to this particular region. And so I decided that I needed to engage, I needed to integrate. And to do that, I scrambled together some money in order to have a dinner for general practitioners. The general practitioners across the region had not had a specialist service in either oncology or palliative care. In fact, they hadn't had any subspecialist services in internal medicine. And we put on a very nice dinner one Thursday evening. I still remember it very well, very vividly, almost 28 years later. Unfortunately or fortunately, we had some very fine wines on the table that evening also. And a few of the general practitioners had enjoyed those fine wines, so by the time it came for a couple of talks after dinner about the plans to work alongside general practitioners, to engage with them, to look at how we could support them in developing their skills, one general practitioner who'd had a glass of red too many got up and said, "You can all disappear. You do not need to be here. We've done this for decades and we do not need palliative care. We know how to do it." Now, I'd like to suggest that if we're going to integrate palliative care, we need to deal with those sort of values and beliefs very early in the process. I'm delighted to say this same general practitioner, within about 2 years, was referring palliative care patients. And when I left that region several years later, it was that GP who arranged my farewell dinner. We engaged, he saw benefit, but it was a long and arduous process. We know from many citations that could be on the screen now that the needs of people are the same regardless of the life-limiting illness they have. The existential issues, the physical issues, the social issues, the emotional issues are identical, and yet our services don't necessarily reflect that today. So what is the equation as we go back to that retired bureaucrat? Our funding base is not expanding. The demands and expectations of our communities continue to grow and to grow rapidly. So we have the challenge of how we meet those expectations or indeed manage those expectations. And the challenge that our mortality continues to change. We're looking today largely at a resource wealthy set of issues, but consider the rest of the world as life expectancy improves, as the shift from acute death to expected death occurs across the world. Here is the call to arms for this morning. We have no gold standard in order to initiate a referral. We have multiple entry points in multiple settings to palliative care, provided by a large number of health and indeed social professionals. Anyone here familiar with Monty Python? Yeah? And Life of Brian? Yes. You can almost imagine the Monty Python quip, can't you? When should we refer? To which Brian responds, you will know when to refer. But Brian, tell us, when shall we refer? Well, you will know. At the moment, that is what we have said to our colleagues. We have given them little guidance, and we are stuck with the challenge that they are supposed to know. In fact, one of my very senior colleagues when I was training said, why would I talk to anyone about referral patterns? I have to trust that the oncologists know when to refer. Not surprisingly, his practice was made up of 98% of people with cancer as their life-limiting illness, no reach into anything else, and no interest even in engaging with the oncologists. So when we think about the development of palliative care, we can think about this as a rite of passage, as the creation of a new subspecialty with all of its strengths and all of its weaknesses. And this was from a paper that was published 16 years ago, really drawing on Van Gennep's work, talking about separation, transition, and incorporation. And that concept in the transition that you actually don't have a home. You've left what you were, and you're still not where you want to be. And when you think about palliative care, there's a lot to be said about that, there was a period of time where, as a social movement, and more latterly a clinical movement, we have seen this shift. In the more recent times, Joseph Campbell had this as departure, initiation, and return. And translated into palliative care, perhaps a period of separation. I don't know that it was quite as long as 1945 through to 1965, but it was to say people who are dying are still part of our health system, that despite the optimism of those years, and you know, when you think about what was available as a result of 1945 to 1965, suddenly you had muscle relaxants, you had blood transfusions that could be given safely, you had a range of antibiotics for the first time. You were changing fundamentally anesthetics, and so you had this wonderful view of the future. Transition, again, I'm not sure I agree that 1985 was the end of that transition. I'd argue that we still actually haven't made that transition fully. And if we think about transition as a state of ill-defined attributes, we may all need to own that today. And I mean we, I'm including myself in that very strongly as we think about that challenge. And finally, incorporation, gaining recognition from mainstream clinical practice. And the article here talked about reforming zeal being compromised. by the process of selling out to being part of healthcare. I challenge that notion. If we are going to meet the needs of the population, we need to be part of the system. Further, not only part of the system, we need to be part of the solutions to the problems that the system has. And if we can do that, then we can look to the future with excitement. I'd like to couple that with a concept of what is a professional, because as we think of professions, and therefore sub-specialties or sub-disciplines within clinical care, we have the very real challenge of what this means. And there are a number of attributes on this slide, but I'd like to highlight one of them. And that is that if you want to call yourself as separate to the rest of the world, you need to have a widely recognized body of learning derived from research, education, and training at a higher level. Now, one of our challenges as we think about palliative care is, do we actually fulfill those criteria? And if we do, are we actually putting that research into education and indeed into training at higher levels? That's the basis around which I want to challenge us today as we think about the next 10 years and integrating palliative care with the care that we offer. Professionals themselves have a number of attributes that we should think about, and particularly the promotion of the public good within their expert domain is one to which I'd like to draw attention this morning. Again, why have I chosen that? Because this is not just about the patient in front of you. If we limit this conversation to the person who manages to find us in the health system and to come to our consultation, we have not fulfilled that criteria in the promotion of public good within their expert domain. So the challenge is that this is not a passive process, and it's a very active process. It's a process that demands of us that we challenge ourselves and each other as we move forward. We talked yesterday about right care, right time, right place. It's a wonderful mantra, and we can all subscribe to it, perhaps, though it's best care every time, in any place, when we think about palliative care. And that's a very different concept. It challenges us to take ourselves right out of our comfort zone and think about the work that we do on a day-to-day basis. So in the next little while, I'd like to explore three things. What is the value proposition of palliative care? I'd like to consider some case examples of interfaces with other services in perhaps a slightly different light, and then think about what can be achieved if we get integration right. So what is our value proposition to the community in which we live and work? Why should the community invest in us? It's a fundamental question, and I think too often in palliative care we think the answer is so obvious that we don't need to answer it. In fact, I challenge us all that we need to answer it repeatedly and iteratively as our evidence base continues to develop. We have a fantastic evidence base, but look at how it's spread. The top three journals only account for 1/8 of our academic output. If you want to get to half of our academic output, 43 journals. I can't even read the titles from the abstracts, let alone get through that sort of information. We do have an evidence base, but it's dispersed markedly across the system. People say there's no evidence for what we do. 1 in every 122 clinical trials ever done is in palliative care. So we do have an evidence base. The question is, are we using that evidence base and really ensuring that we're taking that forward? If we're applying it, are we applying it systematically, or are we applying it selectively? The bits we like to believe and the bits that we're not prepared to believe. There's a huge challenge for us as we think about applying that evidence base. And what does the evidence base look like? Admittedly, this paper draws on data that's almost a decade old. But looking at Journal of Palliative Medicine, and Journal of Pain and Symptom Management, what research was being reported in those top three journals, accounting for 1/8 of our output. Of the more than 400 papers, 429 papers, 189 of them were considered research papers. A few things to notice. Firstly, that the number of prospective studies accounted for just 18% of the work. We're really good at looking backwards. We've got to start looking forwards, and we've got to start doing prospective work in what we do. Although caregivers and family account for more than 90% of all care that's offered in the last 12 months of life, we were far more interested in what health professionals believe than actually what caregivers needed in the work that they were doing. We need to seriously look at the priorities that we have there. And in service provision, we had just 8% of those studies looking at how we provide services. And yet, as we discussed yesterday, and as we discuss at conference after conference, we don't have a well-established model for delivering palliative care that has an evidence base that says this is going to help solve some of the problems in health while adding to the health of the communities that we serve. So as we think about integrating palliative care for patients, for caregivers, for healthcare teams and the system, what do we need to think about? Many of you will have heard me use this paper before, the work of Karen Steinhauser from Duke University, a national randomized sample, asking people what's important at the end of life, asking patients who have been told that they have months to live, caregivers 6 to 12 months after they have finished the role, importantly, doctors, nurses and allied health practitioners. Everyone agreed on symptom control. But I want to make sure that we read the whole line and personal care. How much emphasis do we have in palliative care on maintaining function for as long as possible? I see so many of my colleagues go, well, of course function is declining. They've got advanced chronic obstructive pulmonary disease, they've got advanced heart failure, they've got advanced cancer. Of course they're declining. But how much emphasis do we have on optimizing that so that when you have to ask for personal care is as late in life as possible? Just let's do a quick straw poll to make sure that we've got this in context. Who is looking forward to the time that they need to ask someone else to bathe them? Nope, not a single hand. Who's looking forward to the first time you've got to ask someone else to take you to the toilet? And yet in palliative care, we have not put function nearly highly enough. We've simply stopped at symptom control. And we've then stopped at symptom control without seeing it as an end to a means, and a means to an end. And the means for this end is doing all those other things that are important at the end of life. So symptom control is one small step, but it's not the end of the story. It's so that we can maintain function for as long as possible, that independence for as long as possible, and at the same time allow people to prepare for the end of life, achieve a sense of completion, be able to express their treatment preferences. The fact that patients had to say, I want to be treated as a whole person, says that they don't think they have been, because they need to tell us very clearly that should be what happened. So I'd like to suggest that the goals of care are about optimizing function and comfort in each of these domains, and that simply focusing on physical comfort is a crucial part of what we do, but only the start, and that we need to take that further if we're going to meet the physical, emotional, spiritual, sexual, social and financial needs of the people we serve and their caregivers. What's the burning platform for us? You know, we have point-of-care data collection happening across the country in Australia at the moment. It's taken a long time to get there. And when you look at a paper like this, where we're all taught to ask open-ended questions, how are things? You get people volunteering a median of one symptom. You give them a checklist and you multiply that by 10. You then say to colleagues, well, we found 10 times as many symptoms, and people say, well, they can't be that distressing. Yes, they are. And so we need to be systematic in what we're going to do. The burning platform here is very clear. We're underestimating the physical symptoms, let alone all of the other symptoms that the people we serve encounter. When we asked people independently of their clinicians in a national survey, 25% of respondents had overwhelming pain. 25%. And they were seeing the palliative care service. And I think that's because people give up telling us. We promise them the world, we don't deliver, and by about the 5th consultation, they shrug their shoulders and they go, it's fine. But it's not. Other symptoms, 1 in 6 people had severe or overwhelming symptoms. And then we go to caregivers. 1 in 5 caregivers said the anxiety was overwhelming. Family members, 45% of respondents said they had overwhelming anxiety. And these are people seeing us on a day-to-day basis. So as we talk about integration, I'd like to suggest that part of what we need to do is get our own house in order. That it's easy to criticise our colleagues in oncology, in cardiology, in respiratory medicine, in general practice. We haven't given them guidance as to how and when to refer. And we haven't got our own house in order in some key areas. So as we think about this at a population level, because again, if we're back to the definitions of professionals and professionalism, we have to think about the whole population. I'd like to suggest that the world looks something like this, and for once, for those of you who know me, this is not a 2x2 table. Most things can be reduced to a 2x2 table, but not this one. So on the left, we've got patients. And we've got the majority of patients who actually have great support already and probably don't have highly complex needs. We do risk professionalising death if we believe that everyone who is dying an expected death has complex needs. And for those, if we follow it across, the generalist skills of many health practitioners can help to meet their needs and the needs of their families. We've got a middle group where the needs are often more complex, and you need services with special interest needs, skills. And that may be for a time-limited period, while a particular issue is being addressed. And then you've got the top group, where with the most complex needs, you need specialist skills, and you know those referrals. They're the referrals where at the team meeting on a Wednesday afternoon, it takes up the whole meeting for one family. Now, I think we need to be honest. Chances of actually changing the dynamics of that family are remote. But what we can do is make sure that they get through this process as smoothly as possible. One of the great sadnesses in my research life was that we collected data prospectively for 18 months on complex families at referral. And the person whose computer this was entered on went on secondment for 12 months. The computer lost as it was replaced, and we don't have those data. But it represented in our service, with 1,100 referrals a year, about 80 families that made the criteria for that level of complexity. And so you need an increasing knowledge base and an increasing time commitment as you move up through that patient pyramid. But let's not romanticize the role of caregivers either. Our national government commissioned a piece on people without caregivers, and it got us thinking and has actually bred several important questions, one of which was to ask the whole population, irrespective of health service utilisation, you've just finished the caregiving role at some stage in the last 5 years for someone you love. Would you be prepared to do that again? Now, the community impact of this is enormous. Because consider, the chances of us doing this more than once in our lifetime is incredibly high. And we as a community expect that family members are just going to drop everything and provide that care. Here we've got 1 in 13 caregivers saying after the fact, I'm not going to do that again. And we've got another 1 in 6 caregivers going, I really don't know whether I would do that again. What support are we offering caregivers for them to say that? And certainly increasing age, lower educational levels were two of the major predictors in people's unwillingness to care. This is from the same process. Just over 9,000 respondents interviewed in their own homes on a Saturday morning, asking them, have you had someone close to you in the last 5 years die an expected death? 1 in 3 people said yes. And we asked those particularly who provided hands-on care, have you been able to move on with your life? And across the x-axis we have years since that death, and on the y-axis we have the percentage of people who are able to say, I have been able to move on with my life. And I want to draw your attention to that magenta bar over on the right-hand side of the graph. At 5 years, 1 in 7 people are saying, I have not been able to move on with my life as a result of that person's death. Not about forgetting about them. Moving on is integrating that into your life and creating that new life without that person. Now, I do another straw poll everywhere I present this slide. Anyone here from a service that has a mechanism of identifying the 1 in 7 people, 1 in 7 people who say at 5 years, I've not been able to move on with my life? Because I certainly don't. I've been to presentations where people argue about whether a phone call at 6 weeks or a handwritten card at 3 months is what should be done as a result of death in palliative care, but I have not come across a service that says we can do something about those people whose lives have literally stopped as a result of that death. Primary care is not well equipped to identify those people. Specialist services do not have mechanisms, and yet if we want to be integrated, we've got to be part of the solution for health systems. And this is a massive challenge for those individuals, for their families, and for the health systems trying to match up this person presenting 5 years later, if they do present, with an event that is really quite remote from that. A big challenge for us. And what about health service utilisation? You know, we've got good evidence from population-based studies that referral to palliative care can have an impact on emergency department presentations, for example. Now, where are the pressure points in the health systems in which you work? The ED is the one place that's open 24 hours a day, 7 days a week, 365 days a year, right around the world. And it's a place where there is enormous pressure. If we can reduce by 40% the number of people who present there late in life because palliative care is involved, it would seem like a really good investment. Or the readmission rates for people, again, in the last 30 days of life, if you had home care versus not having home care. Again, it would seem a really sensible investment if we're going to make a difference to end-of-life care. So as part of the value proposition, the question has to be asked, why should anyone integrate with us? We reflected yesterday afternoon in the workshop, importantly, that we were always having to reach out in palliative care. There are lots of reasons for that, and I'm delighted to talk about those over a glass of red at any time. But I'd like to suggest that we have a fundamental challenge, that we still haven't convinced our colleagues of the value proposition. So what about our interface with other services? As we think about that, let me start with Choosing Wisely. Choosing Wisely was an Institute of Medicine Foundation initiative to specialties across the United States and subsequently across the world to look at low-value practices, identify those low-value practices and say, let's stop them because we not only believe it will not have an adverse effect on the health of our community, it may improve it. Now, this isn't to criticise the individuals. Again, I stress this is a conversation behind closed doors today. But palliative care, 4 of the 5 things that they put up initially were about pointing at everyone else. The cardiologist should be better at turning off defibrillators. The radiation oncologist should be better about single fraction therapy, and so it went. Well, let's look at our own backyard. We've got low-value practices that are part of our mythology that will continue until we actually say this is no longer acceptable. And so as we think about integration, we're not doing ourselves a great deal of lots of favours by saying to our colleagues, you're doing it really, really badly. And yet that's what the Choosing Wisely document said. You're all doing it badly, but we're not. Now, I don't know about you, but that's not going to go well with my cardiology colleagues. It's not going to go well with my colleagues in radiation oncology. Alicia Ward did a study which was published in Palliative Medicine. I'm sorry, I missed out. It was published in Palliative Medicine, down the bottom there, in 2009. She asked oncologists' attitudes to palliative care. Now, Alicia is a very diplomatic person and framed this in the positive, that we need to improve resources, we need to improve multidisciplinary links. Read that as a negative and see what you come up with. We need better mutual respect and understanding. Now, if the Secretary of State for the United States said we need better mutual respect and understanding, we all translate that and understand exactly what he or she was saying. And we need consistency in service provision. Now, what was meant by that? I think, again, we're back to criteria for when you do refer, when we're going to discharge, actually providing a framework. And we're going to return to the word framework very late in this talk. But in consistency in service provision, one of the words of the respondents was palliative care is really good at cherry picking. Now, I don't know if that translates well into other languages, but cherry picking means you pick the best things and you leave the rest. Now, I don't necessarily believe that that's the case, but we've got to listen to the perceptions. And here were respondents saying they're cherry picking. And one of the criticisms in the consistency in service provision in cherry picking was we had services who simply said, we're not going to have anyone go on call. Everyone else can take the 2 a.m. call from the emergency department, but we're not going to do it because we're very, very special. The resources were there for it, but they had unilaterally decided they weren't going to fly. Now, again, if you're one of our colleagues, why would you want to integrate with a service like that? You end up carrying all of the difficulties that are associated with it. And so we come to this beautiful little study by Bruce Foggo. It's probably not a study that you've read, but I love the backstory to it. So, 2 patients, consecutive rooms in a hospice. Patient 1 is told that they need to go to a skilled nursing facility because they're going to be alive too long, essentially. Patient 2 is told that they can stay. Now, what we don't realise is that patients' families talk to each other. This study grew out of 2 families in adjacent rooms with identical diagnoses in someone who was the same age with the same comorbidity. And so Bruce turned up to a family meeting with family number 1, and there was their lawyer, their attorney, their solicitor, sitting in the corner taking notes. And he challenged the service. He said, why are you referring us? Well, you know, the answer's pretty simple. You bring your lawyer along to family meetings. Of course we don't want you on the campus. Not that you can say that. And so this team then went away and looked at what they did. And sure enough, patients who were low maintenance, who had nice families, who bought lots of chocolates and thanked the staff lots, were far less likely to be referred on to a skilled nursing facility. Now, if that happens in referral from palliative care, yes, we've got evidence in referral to palliative care. But we're likely to get people who other services have had difficulties with. And that's probably really appropriate. But again, we need consistent decision-making processes that are transparent to patients and indeed their lawyers. I also want to focus, as we think about other services, in thinking about the issue of the change in therapies that are available. I'm going to use an oncology example, but there are equal examples in end-stage respiratory disease, end-stage renal disease, end-stage heart failure. And so this was an editorial by Robin Ward, someone with a brain the size of a planet. And she points out that in terms of targeted therapies, biological therapies, with the notable exception of trastuzumab for breast cancer, the improvements in disease have all been built around late-stage disease. Every single one. There are no other registered medications at this stage for an adjuvant setting from the very expensive end of drugs. So that has a real challenge, because it means that you and I are going to have to get to know a large number of drugs if we're going to provide really good care. Because these were people who 5 years ago would have been referred to us and we would have been very comfortable with their management. But their management has changed dramatically, and we have to keep up with that. Yes, we need to trust our colleagues in oncology, but at the end of the day, this is shifting. And so yet this end-of-life focus discourages investment in areas where patients and society may well be better served, i.e. us. So we've got to be out there actually having this conversation with funders, with policymakers, and with others. And whether it's targeted biological therapies in oncology, whether it's left ventricular assist devices, whether it's non-invasive ventilation in respiratory disease, the problem is that the science of everything else is rapidly going forward. And we have to answer the fundamental question, does this person have a life-limiting illness? Because a life-limiting illness from 5 years ago may not be a life-limiting illness in the same way today. The challenge for all of us in this room and for the services that we provide is that is a huge and almost insurmountable issue unless we integrate. And that integration is a two-way process. It's us integrating with a whole lot of our referral services, as well as hoping that those referral services will integrate with us. So what can be achieved if we get it right? As I pointed out already, we've got no gold standard in order to initiate referral. We've got multiple entry points, multiple places of care, and a large number of health professionals providing this. So I'd like to suggest radically that if we're really serious about this, the services we represent have a challenge. And that is a challenge to fundamentally shift the workload program that we have. There will always be more patients to see. Always. So we need to see the people with the most complex needs. We should never look at a clinic list, a home visit list, or a consult round list, or our inpatient list and think it's going to be a good day. We should be seeing the people with the most complex needs. But at the same time, and this harks right back to Cicely Saunders' writings in the late 50s and early 60s, we need a research agenda that is strong, that covers the complexity of the care that we offer. I would suggest is not just about patients, but about caregivers and the health system, as well as the population we study. And that we need education. And that education is not just about new graduate health professionals. That education is about the community and the conversations we have with the community. It's also about our currently established health professionals. Most registered health professionals out there trained when palliative care was not part of their curriculum. And roughly half of the health professionals out there trained when critical appraisal was not part of their curriculum. We've got a big task. And we're not going to do that just by seeing patients. And we need to put a ring fence around that so that education and research become integral to what we do and how we see services if we're going to have something that other services will want as part of their team. In national curriculum development, we put together work led by Patsy Yates, looking at 4 domains, the individual attributes, the clinical skills, the communication skills, and some palliative care principles. As we think about infiltrating this into existing curricula, 3 of those 4 can be woven into curricula without mentioning the word palliative care. Most importantly, in coming of age, we've got the second generation of practitioners in palliative care out there. The Mavericks have done their job, and they have done a fantastic job. They were Mavericks, and Mavericks by definition have to be single-minded. Doesn't mean they all get on with the other Mavericks, and that's okay, but this generation, we've got to do it. And that's our opportunity, and we've got, as I say, I believe, a very narrow window of opportunity to get this right now. Otherwise, we will continue to be funded simply as a social good, as something to relieve the itch of the community believing that something is done about people who have a life-limiting illness. Today is a mirror because it's what can be achieved if we get it right. It's about thinking of those other service providers and really working hard. When I was a student, I did a general practice attachment with a very wise general practitioner. And in the top right-hand corner, it's the days they used cards about 5 by 9 inches, there was a circle and a dot for every patient. The circle was drawn there, and the variable was the dot. Was the dot inside the circle, outside the circle, or somewhere over on the wall? And this was her shorthand for saying, where's this person's locus of control? A really nice way to do it. And if the locus of control was out here, she knew that there were going to be some different challenges in providing care for that person. I'd like to suggest that palliative care in 2016 needs to ask, there's the circle, where's our dot? It was interesting yesterday that in the consultation, the word passive was used many times. We are the passive recipient of referrals because we haven't created a framework that says, here's when and how to refer. We are the passive recipient of funding because we have not sufficiently made a case to say this changes the health of the community in which we live and work. And as a result, this investment is one that should be made. So, if you're only awake for 30 seconds this morning, sorry Phil, this is mine, 30 seconds this morning, this is it, you can go back to sleep now. Needs-based palliative care is the way of the future. We need to see the people with the most complex needs with the health professionals that have the skills to deal with that. And we need to make sure that other people whose needs are less complex are seen by people who have skills and interest in the area, and to ensure that at a population level, their needs are met. We need to have referral and discharge criteria from specialist palliative care services. It is not till death do us part just because someone was referred. Let's make sure that we have evaluated and re-evaluated the need for the continued involvement of specialist services. So we, in palliative care, need to get the framework right, and this current project has been a crucial step forward in helping to create that framework. Fantastic work on which we can build for that conversation. When we've got those frameworks in place, I guarantee that we can develop the networks far more quickly, far more efficiently, and with a far more collegial approach than we've experienced today. It is indeed that simple. I'm going to finish with this quote. Graham Innes was born and lost his sight at a very young age. Has used a guide dog and travels around the world advocating for people with a disability. He was our Disability Discrimination Commissioner, as you can see, for 8.5 years. He talks in both his writing and his lectures of the soft bigotry of low expectations. I'd like to challenge us all this morning that we are victims of the soft bigotry of low expectations. From our colleagues, from the community, and sadly and most challengingly, from ourselves. We have a really bright future. We know we can make a difference for patients, for caregivers, for health teams and the health system. But we need to be out there with a clear framework a clear framework that allows our colleagues to interact with us predictably, transparently, and in a way that will ensure that we are indeed going to deliver the best possible care. I'm happy to take some questions or comments.
Thank you, David. Well, that certainly got us thinking, didn't it? Any questions? Chris?
David, thank you for your very inspiring lecture from down under for us. Yeah. You mentioned one thing not that strongly, and I'm very curious about your thoughts to give to the audience, because in Europe, in the Netherlands, we are discussing very strongly the situation of the word palliative in this mission. And you want to go to the improvement of healthcare outcome. Yeah, it was one of your first slides, but they repel us always back to the situation that you are palliative, you're at the end of life. So can you give some advices for us how to overcome that wall?
Yeah, so the question is, how do we overcome the wall of palliative just being end of life and that consistent pushback? Look, my view, and it's a very personal view, is that we've got to stop finding new words. We just have to stick to a word and get the marketing team out there. I work with some extraordinary marketers in my substantive role outside palliative care. They can sell anything. They can sell fridges to Eskimos. And I think we've just got to get out there with the message that this is actually a great investment in health, and that signing up for this is the most sensible thing that you can do. I mean, we have a challenge at a systems level of the number of people going to intensive care, for example, in their last hospital admission, and we look to our colleagues in the United States for the crystal ball of what it may be like if we just continue unabated. So there's always going to be a problem with the word. Whether we have hospice or palliative or supportive or whatever we want, there's going to be a problem. Let's get the marketers out there and let's be on our front foot in taking forward the opportunities of improved health outcomes.
I'd like to make a comment about that. When my charity did a serious piece of market research on how to change from being a charity which is concerned with cancer care to one that's concerned with the care of the dying, we struggled hard to put something on our as a strapline, and the message came through loud and clear. The public didn't really understand palliative care, supportive care, end-of-life care. They didn't really get that. What they understood was terminal illness. They understood that. And the great thing about that is it opens up a space between where you are now and when you're going to die. And so I think we need to be seen as useful for people and families who are engaged with terminal illness. And I think actually, if you think about that word, it's been around a long time. It takes a long time for the public to understand these things. And inventing another term is probably going to get in the way.
I agree strongly, Bill. And let's face it, I'm walking here this morning, I walked past a garbage truck that said, Shank Brothers doing great things with garbage. I mean, if they can get a byline, a strap line, then surely we can get something in the work that we do.
Any other questions? Thank you.
Just a comment. I really enjoyed your talk. I just think I wonder how you felt about it. We in specialist palliative care service have a vested interest in not saying no to referrals. So the temptation is that we always say yes, we take on this referral. I think it's quite difficult for services to say, well, actually, no, we don't need to take on this person because it's about, generating, minimum data set and getting all this referrals and how we are needed and how we need funds.
Yes, you touch on it at the end, the need to be needed. Look, I've seen services who actually now do triage really actively. Their commitment is to a single comprehensive assessment, and then a decision is made as to whether the team can value add or the person's really well supported. And I think, so much of what we do is validating other people's practice, which is a good thing. I say that in the most positive sense. You haven't forgotten something here. I do the same thing with renal medicine. I'll often ask for a consultation just to make sure that there hasn't been an advance that I've missed. And people do that to palliative care, and we need to be cognizant that supporting our colleagues in that is often one of the reasons for referral that they will never quite articulate in that way.
David, thank you very much. That was an excellent start to the day, wasn't it?